So I think I'm going to get started now with some intros. So thank you again, everybody, for joining us. I'd like to extend a really warm welcome to everybody. I'm Raphael, and I work on the operations side at Care Oncology Clinic. Delighted that we're here today with Jane McClelland and key members of our clinical team from the US and the UK. We're particularly pleased to be sharing this platform with Jane because we have a common goal, and that's to change the landscape of cancer treatment. Huge strides have been made in recent years in terms of research, with new conventional treatments coming online, immunotherapies, targeted therapies, and combinations of these. However, outcomes in many cancers are improving, which is great, but there do remain types of disease, particularly aggressive tumors, late-stage diagnoses, where standard of care sadly doesn't have all the answers just yet, and patients are in great need of additional options. So Jane has done and continues to do a quite incredible job alerting people to all areas of research and treatment options. And historically, these areas of research have received very little attention. And in parallel, Care Oncology's founder, Dr. Robin Bannister, first sought to use his deep knowledge of drug biology to help his wife, Ginny, when she was first diagnosed with metastatic breast cancer, and he extended that ambition to the not at all trivial task of establishing a clinic to provide medical oversight with experts in metabolic oncology, to collect data and ultimately reach much larger numbers of patients to deliver coherent and evidence-based protocols for adjunctive therapy, to complement the conventional cancer treatment that is out there and directly address this, what is in effect an unmet need. I just had a few points to cover off before we get into the presentations, the introductions and the presentations. First of all, I would just like to say that Jane McClelland's protocols and Care Oncology protocols are not exactly the same, and you'll hear more about that from the panel, from Jane herself and from the COC doctors. And also to make clear that Jane is not an employee of Care Oncology, has not been compensated for her time today. But what really brings us together is our common purpose, that we must search for answers beyond the current standard of care treatments. The progress is often slow, too slow, and patients need and deserve more. So there's a good deal of ground to cover today, and there'll be a lot left to say at the end. So I also wanted to signpost, this is only the first of several planned sessions at COC that we plan to do with Jane. We learn from our patients every day, and we want to continue to build a community. And therefore, we have numerous further events and follow-up planned to address more topics, answer more of your questions, and also bring other experts into the conversation. This session today is being recorded, and we'll advise how it can be watched back. So now I'm going to hand off to our wonderful panel to introduce themselves. And that will be followed by short presentations on the role of metabolic therapies in cancer. This will focus on the work of Jane and also the COC. And following that, we'll spend a little bit of time outlining Care Oncology's new COC Plus program, and then we'll answer your questions. So just like to start with you, Jane. If you could introduce yourself, that would be fantastic.
Unmuting myself is a good idea as well. Hi, thanks, Raph. Did you want to just say your black eye was as a result of a gardening incident as well?
Yeah, nobody believes me, but yeah, I've turned up with a nice shiner. It was a gardening mishap. My 5-year-old was to blame, which is a bit embarrassing. So just suffice to say that he can throw a hard rubber ball, well, much harder than I thought he could. Anyway, over to you, Jane.
All right, so yes, I think a lot of people do know me already. I'll go through my story in brief when I go through my slides. But yes, I am a long-term cancer survivor, put together a protocol back in 2003, which is very similar to the one that the COC used. So that's me. And I'm not going to say much more at this point, but thank you, Raf. Thanks, COC, for having me with you.
And Kuhan.
Yeah, thank you, everyone. Thank you to my esteemed fellow panelists, my team at COC, whose commitment and dedication to the growth of this clinic has been integral to its success, and thank you to the esteemed audience. My name is Dr. Hariharan Kuhan. I'm the full-time medical lead at COC UK and have been so for the past 3 years. I'm a London-trained medical oncology doctor with experience in research, performing a PhD in cancer metabolism and pancreatic cancer stem cells, but also extensive experience in early phase clinical trials, particularly adoptive cell transfers like T lymphocyte therapy. Those are the sort of stepping stones of experience for me to come on board with Care Oncology Clinic, where I wholeheartedly joined in the summer of 2019 with the mission of carving my own path. And it's a pleasure to have some time with you today.
Thank you, Kuhan. And Dr. Kesslering, if you'd like to introduce yourself.
Sure. So my name is Dr. Christy Kesslering. I'm a board certified radiation oncologist in the Chicago area, trained, Bachelor's of Science at UCLA and the med school at Loyola outside of Chicago, and then residency at UW-Madison. And I've been practicing radiation, or I was practicing radiation oncology for over 20 years in the Chicago area. But I knew that something was missing from standard of care oncology. And I think we've seen lots of links to diet, lifestyle, metabolism. And as I became more familiar with the idea, I got myself additional education in the area and really dove into metabolic health and opted to leave my own practice because I'd already been incorporating that into some of our patients, but I really wanted to do that full time. I felt there was a huge need for that piece. And so I've been fortunate enough to help integrate maybe a new program into the COC protocol area called COC Plus, and we'll review that later, but I'm really excited to introduce that and how we can utilize it to further optimize our patients' care.
Fantastic. Thank you, Christy. So if I could hand over to you, Kuhan, to just begin. One second, I'm going to just unshare and then reshare again until my slide deck was stuck.
I can start talking now. So guys, I mean, obviously receiving a diagnosis of cancer is overwhelming, an understatement. Putting the emotional trauma to one side, the information overload in this day and age of information is quite something. Friends and family will have advice, a simple Google search or dipping one's toes in the world of Facebook will leave your head spinning. Regardless, a patient or a loved one of a patient will make it their mission to read and learn as much as they can to seek options to regain the reins of control. And that's the world we live in. The paternalistic relationship between an oncology doctor and patient is somewhat being eroded for a variety of reasons. Patients have access to more information, therefore more questions. I personally consider my role as a doctor to be an educator as well, but you often hear about issues with poor communication, a lack of rapport or support or even trust between doctors and patients, public sector pressures and time constraints likely being contributory factors. It's not surprising that with disappointments in the cancer journey, the seed of doubt in the healthcare strategy is laid and that a realization sets in that one needs to do more for themselves. And what we practice in the mainstream is defined by the highest caliber of data, randomized controlled trials, guidance defined by scientific method, presented in academic forums with exposure to scrutiny and debate, but the solutions are finite. Understandably, patients want to do more to optimize their outcomes. Often with all the reading of the books, such as How to Starve Cancer by Jane or Tripping Over the Truth by Travis Christofferson, engagement on social media forums and extrapolation of information that seems relevant, more and more questions build up, resulting in a logistical nightmare. What's the best way to incorporate all of this? The art is trying to be defined. Thank goodness people on many fronts are fighting the good fight to help, including integrative practitioners, functional doctors, and cancer nutritionists. The harsh disconnection still exists between mainstream oncology and everything else. Often each side casts shade at each other, but actually in recent years, there's been a greater acceptance of the worth of complementary and more holistic treatments. Treating people as a whole and not just focusing on executing a predetermined protocol and putting out fires, so to speak, is finally being recognized. The interest around the cause of such fires and preventing them is now very much at the forefront of certainly COC's movement and others. The message is that more needs to be done. Drug development is sluggish. Patients need to meet various inclusion criteria to enroll and access novel treatments, and current treatments are somewhat old and a little bit outdated. We need more strategies to attack this disease on multiple fronts and converse about preventative strategies. Amidst this complicated landscape of options, COC began focusing on one aspect of all of this, determined to enhance outcomes. Slide 3, Raf. The Care Oncology Protocol is an adjunctive protocol of agents that can apply a multi-pronged suppression on important metabolic mechanisms pivotal to cancer cell growth, division, and spread. Its creation organically fueled by a very personal set of circumstances, as Raf mentioned. Care Oncology Clinic was set up in the UK in 2013 to provide metabolically targeted agents as an adjunctive treatment to cancer patients in a safe, structured manner. Since then, we've seen over 4,000 patients in the UK and over 5,000 in the US, and continue to grow. We set out to deliver an accessible and affordable treatment option immediately available to help today's patients live longer and better lives. And beyond empowering patients, we also sought to collect and report on our data in a meaningful way with the intention of changing the landscape of cancer treatment and putting anti-metabolic therapy on the map. Slide 4, Raf, please. The COC protocol is based upon the work of German scientist Otto Warburg in the early 1900s, who received a Nobel Prize for his research on the unique cellular biology of cancer cell metabolism. In the following 100 years, many studies have demonstrated the potential utility of existing agents in cancer metabolism, particularly in combination with existing standard of care therapies, like chemotherapy, radiotherapy, hormone treatments, and immunotherapies, for example. I mentioned before the word logistics. There can, of course, be problems with using extensive lists of chemical agents without some applied thought. Agents can interact badly with one another, they can cause side effects, they can affect the liver function and disrupt the breakdown of other agents, they can affect the mainstream treatments or mainstream avenues of treatment. It's well known in the medical profession that polypharmacy is notoriously a danger. The COC protocol was derived from an exhaustive literature review, and in collaboration with senior academic oncologists, it comprises chemical agents that have preclinical data supporting their effects in cancer cell metabolism, agents that have been evaluated in large data sets in population studies, agents whose human effects against cancer have been observed within currently prescribed dosage ranges, and agents that have been safely co-administered to cancer patients alongside conventional cancer therapies. Slide 5, please, Raf. The complex nature of cancer cell metabolism requires multiple mechanistic points of intervention for optimal effect. Putting all the eggs in one basket and hoping for one-hit wonders and with a unifocal strategy will not have a durable effect logically. The tools used at Care Oncology are not solely for targeting metabolic mechanisms, such as the regulation of sugars, fats, and glutamines, but to also address other specific and well-established pathways at a molecular level. And both Jane and Dr. Kesslering will expand on this further. Care Oncology Clinic was created to address these problems and make the metabolic treatment safely available to patients with ongoing medical supervision. Understandably, medicines are more straightforward than other interventions. They're consistent, licensed products, always manufactured in accordance with GMP, good manufacturing practice, and therefore can be studied. Therefore, there is more data in humans and more data in cancer than exists with other interventions. Although the primary aim is to treat patients, I mentioned we also seek to audit and report upon safety and efficacy data regarding the use of the COC protocol alongside standard of care. Our physicians, through their various medical backgrounds and experience, are specialists in metabolic oncology and always on hand to ensure patients are taking adjunctive treatments in a safe, structured and coherent manner to ensure that they are not putting themselves at unnecessary risk. As I mentioned before, COC doctors find that patients are often overwhelmed with information and treatment options, and we seek to provide a framework for decision-making, help our patients understand the quality of data presented in scientific papers, and weigh the risks versus benefits of different interventions. It's important to stress that the clinic adheres to the core principles of clinical governance and is CQC inspected. With the help of our dedicated administrative teams and management, we pride ourselves in having a 2-day turnaround time for new patient inquiries and trying to take the stress out of arranging consultations and follow-up queries with easy channels of communication, something often lacking in the public sector. As a team, we like to believe we have our fingers on the pulse of this complex landscape, and through perpetual discussion and debate, drawing upon the extensive expertise of our health professionals, strive to also evolve our services to better serve our patients, as Dr. Kesslering will go on to elaborate. Slide 6, please, Raf. What I would like to do now is briefly present a snapshot of our glioblastoma data published in the academic journal Frontiers, following the work of my senior colleagues, Dr. Padman Vamadevan, Dr. Ndaba Maziboku, and Dr. Samir Agarwal. Glioblastoma is a form of primary brain cancer that is aggressive, fast-growing, and notoriously difficult to treat. Large cohort studies had quoted a median survival from diagnosis as 14.8 to 15.8 months with conventional treatment. Treatment typically involves the use of the COC Protocol, which involves surgery, 6 weeks of adjuvant chemoradiotherapy, and 6 months of follow-up chemotherapy temozolomide. A second-line option of PCV or single-agent lomustine exists, but beyond this, no good systemic treatment options are available. Just under 100 patients with GBM who first attended the clinic between 2013 and 2016 were reviewed. From a safety perspective, 85.3% of patients tolerated all protocol agents, and there were no serious adverse events reported, which is a very important validation of the non-toxic nature of this protocol. Our analysis revealed that with the use of our adjunctive protocol, median survival time from diagnosis was 27.1 months in this cohort, compared to 15.8 and 14.8. As an extension of this data, the 2-year survival in the COC patient cohort was found to be 64%, compared to 26.5 and 28.7. So something very, very interesting was happening there. With that said, thank you very much for your time and attention. I wish you all the very best with your respective fights against this disease, and I will now pass the mic back on to Jane McKelland.
Jane, you're on mute.
I thought I'd just taken it off. Apologies. Right. So thank you, Dr. Kuhan. I was just wondering, before I move on to my slides, your GBM data is very interesting. There's a lot of people who have criticized it because you don't have a control arm with it. So the control, I assume, is against the normal progress and a comparable set of patients who are in the same circumstances, presumably. But have you seen results since you finished that in 2016? Have you seen, because patients are maybe finding you a bit earlier, have you seen results have actually improved since that study? Or have you got any more comments to make on it?
Yeah, no, really fair question, Jane. I mean, you're absolutely right. I mean, the study was indeed observational, but the evidence, I mean, it's real world evidence reporting a good sizable cohort. And I think the message was very hard to ignore, even though the data was preliminary. In this space, I guess with the lack of pharmaceutical-backed funding for extensive randomized controlled trials, triangulation of data from different sources is needed as a starting point. As a clinic, we've spent some time consolidating the reputation and the safety of the clinic, trying to establish trust and develop relationships with mainstream physicians, but it's been an uphill battle, trying to dismiss preconceived notions about our work. As one can imagine, setting up a randomized controlled trial and excluding compounding factors or bias isn't straightforward, and there are many angles to consider. But garnering such relationships with academic institutions then opens the door to collaboration, and we're actively exploring partnerships to run further studies and ultimately recruit large numbers of patients at diagnosis. Now, I'm very happy to be able to feed back that one of our senior colleagues, I mentioned him before, Dr. Samir Agarwal, actually presented our GBM data just last week at the British Neuro-Oncology Society annual conference. The feedback was overwhelmingly positive, and interest has actually now been shown by many esteemed consultant oncologists and neurosurgeons to move on with this. And so talks are now underway to try and move to the next step. At COC ourselves, we have conducted a further internal audit of our GBM data to track longer term survival. And I do hope to be able to share the outputs of this in our future sessions.
Fabulous. Okay, thank you very much. I'm going to now share my screen. Let's just go from the beginning. Come on, there we go. Okay, so I think people may be familiar with my book, and I also have an online course. I've just made a little discount coupon for people who are on the call here for the next day or so. So if you want to sign up, if you haven't done, I'm going to rattle through quite a lot of stuff very quickly. We haven't got a huge amount of time now. Obviously, my course is much more in depth. So just to let you know that. Right, so we know that normal healthy cells can tolerate periods of fasting and a reduced access to nutrients. Cancer cells, on the other hand, cannot. They always need lots of fuel because it's a process of needing lots of ATP, that currency of energy for creating those daughter cells. And as Dr. Chi Van Dang says, cancer cells are addicted to nutrients. When they cannot consume enough, they just wither and die. So my approach was to use my 4 pillars, which obviously included a low GI diet. I did exercise quite intensively, and I think a lot of people don't use this enough. I think there's very good evidence to show that it is incredibly useful, maybe reduces metastases up to about 50%. I did use quite a lot of supplements, and I also eventually at the end, I used these off-label drugs as well. And I have this approach to cancer that it's a little bit like looking down from an eagle eye, looking down on Piccadilly Circus. Traditional approach is to assume that cancer is just a bunch of genetic mutations. So if you're looking down here, you can kind of see the main avenues into Piccadilly Circus and lots of people milling about. But this is a little like the P53 gene, which was discovered back in the 1950s. And this then became the big thing, that everything was down to the genes. And you've got these other, lots of other key mutations as well. But what you don't see is what's happening underground, which is kind of like the cancer metabolism. And I kind of liken it to trying to get to Piccadilly Circus. If you can't get there one route, the cancer cell will just find alternative routes to just come back in and get back to Piccadilly Circus. We know that traditional treatments are not very effective and that they don't wipe out the cancer stem cells. So this is chemo will take out the bulk of, and radiotherapy will take out the bulk of cancer cells, but these stem cells are left behind, and these then become a resistant tumor. And in that mix, we know that some of those cells will be glycolytic, some actually will be using more oxphos, some will be actually consuming lactate, which is the byproduct of this fermenting process, the glycolysis process. Some of them become addicted to glutamine, some are addicted to cholesterol, and of course you then have the influence of these genetic mutations, which then affect the metabolism of the cell as well. So going back to this, we then see that in this mix here, you could have that mix of glutamine addicted cells or cholesterol addicted, as well as the glycolytic cells as well. So the point is that you will not wipe out an entire tumor if you just use one approach. You have to use a combination. And we know that traditional medicine is against polypharmacy. So you need to have good quality, safe medicines to add, or safe supplements to add. And another reason that a lot of this conflict may be because you've got drug manufacturers who want to just have a hold on the market, and they don't want something else being added to their own drug. This is a very interesting demonstration of the difference between temozolomide, which is a brain cancer drug, and metformin. You can see the results for TMZ here. The cancer kill was around 35%, whereas metformin on its own actually did better and had a cancer kill of about 40%. However, when you add them together, and this is the key, it's the combination that produces a much better result. So this is what most people know me for, is my Metro map, and this is a little synopsis of the key metabolic pathways that cancer will use. And I divide it into the sort of the 3 macros of the diet. So glucose being the carb, the protein is mostly glutamine, and then the fatty acids along the bottom. So these are the entry points for, or the points that, or the nutrient fuel lines, if you like, that cancer will use for the glucose. And then you've got some protein pathways and fatty acid pathways as well. The glutes are, these are glucose receptors. Insulin, I know Christy will talk a lot more about insulin with the COC Plus. And of course, you've got the low GI, exercise being really important. The lifestyle side is also very key to this. And then underneath all of these pathways, I've actually got the drugs or key supplements that either I use or part of the COC protocol as well. And what we're showing, Professor Lisanti, who I'm sure some of you are familiar with, showed that if you block the OXPHOS pathway in cancer cells, it then uses more glycolysis, and in fact, the other way around as well. So it's a sort of a, you block one pathway, and like I said, with my analogy to Piccadilly Circus underground, the cancer will just reroute and come in a different route. So the key is to make sure that you're blocking synergistic pathways, and different cancers will have different dominant pathways. So you will need to look at which ones are more specific for you. You'll find a lot of that kind of information in the literature in PubMed. So it's well worth doing a little bit of research just to feel confident that you are actually attacking your cancer in the best way possible. I also did a quick synopsis of the cancer hallmarks. So I've condensed it down into sort of a 5 key step process, not entirely straightforward process of one to the other. There's lots of interlinks between the two, but essentially we know that the tumor microenvironment is absolutely critical for stimulating the cancer cell, and this is why it then leads, you've got signals that go into the cell and then stimulate this abnormal cell metabolism. This is the metro map, and then it leads to spread and growth. So we've got growth factors and MMP. These are matrix metalloproteinases. These break down the matrix around the cell and allow cancer cells to split off and spread through into the bloodstream. And then you get this abnormal immune response where the immune system no longer recognizes the cancer as foreign, because it's actually converted some of your normal macrophages into tumor-associated macrophages, and these kind of cloak the cancer from being killed off by your immune cell. And this is a result of sort of the lactic acid, which is from the glycolysis, and also some of these growth factors, particularly transforming growth factor beta and VEGF. And this then leads to, because the immune system is no longer controlling the cell division, you then get this fast cell division. Very brief. I didn't go over this in much more detail in my course, but this is looking at my cancer markers from when I was diagnosed as stage 4. This doesn't go back to 94, but because I didn't test them before that, when I was diagnosed with stage 4 and then had surgery, my markers then shot up to about 600. This is the SCC antigen. It's specific for cervical cancer. And then after chemo, my markers dropped right down. I was having berberine at the same time and quite a few supplements as well. And then I sort of potted around. I did lots of intravenous vitamin C, but then when I added aspirin and artemisinin together, I had a major drop in my markers there, which was terrific. Unfortunately, we bumped around a little bit more between then and 2004. I also had myelodysplasia. I have another graph which shows what happened during that time, but that was pretty scary. And that was when I decided to then include some of these off-label drugs, because the diet, the exercise, the supplements, they weren't enough for me. I knew I had to then up my game and then add something a little bit stronger. So dipridamole is an antiplatelet drug, and it was shown in the 1980s to have quite a significant effect on blocking the growth of melanoma in particular, but it also has other effects on the blood as well. And because I'd had this myelodysplasia, I was quite concerned about that, and I thought that would be a good thing to add in. A lot of what I did was sort of gut instinct at the time. I've since worked out why these things worked. But back then I was kind of like a little bit of a wish and a prayer. Berberine, I had investigated. I didn't know anybody else who was taking berberine at the time, but my research had shown me that this was really quite what I term a big gun. And it's very similar to metformin in many respects. The lovastatin and etodolac, I had researched and I saw that if you add the two together, the cancer kill was 5 times more effective than either one of those on their own. So I actually got my oncologist back then to add that into my protocol, which I don't think you would get these days. Very rare. Anyway, back in 2007, I was then in remission. And I decided at this point, having looked at the research into metformin, that this would be a good addition to my remission protocol. I also took cimetidine because my immune system was really rubbish. I didn't know I had cystic fibrosis at the time. But anyway, the metformin has been amazing for my cystic fibrosis. Diagnosed that in 2020, just as we went into lockdown. So I didn't know. I've had it all my life, and I wondered why my immune system was so rubbish, but metformin is actually very anti-fibrotic as well. So I think it's had huge effects. I've actually reversed a lot of the fibrotic changes I've had in my lungs. So these are some of the things I use in my protocol that were very similar to the COC. So metformin, I can show you that it targets quite a few of these pathways. So it targets IGF-1, it targets mTOR, which is like a protein switchboard that sort of triggers the division of the cell. Dipridamole blocks the nucleoside salvage. It also blocks this SREBP2 pathway, which is an alternative cholesterol pathway, and actually blocking that can sensitize cells. Linda Penn has done a very good study on that, that blocking SREBP2 makes your statin work a lot better. There are natural alternatives like luteolin, which can help block the SREBP2, and delta-tocotrienol as well. So this is just an overview of some of the things I did, you know, as well as the lifestyle stuff. I also took DHEA. I didn't take niclosamide or some of these other things, 2DG, DCA, didn't take those, but some of these I did. And then I came across the COC in 2015, having for years tried to get cancer patients to use off-label drugs. So this was a revelation for me that we'd finally got to this point where we actually had a study looking at some of these key drugs. And this was when I set up my Facebook group. And you can see the Care Oncology, their cocktail is metformin, atorvastatin, mebendazole, doxycycline, and in some cases they use flarin, which is also a non-steroidal anti-inflammatory. It's ibuprofen in liposomal form. Very similar to my cocktail. So, what I want to state is that there are pleiotropic effects. That means these drugs can target many different pathways at the same time. And this is really key because you don't want to have an enormous cocktail. You want to have drugs that really will have an effect on many of these different pathways and have ideally as few as possible in order to achieve what you want. And I think a lot of people throw absolutely everything in. But I think really people need to focus on trying to find the key dominant pathways and focus on those predominantly to begin with before they add other things in. So this is, if anybody doesn't know my Facebook group, you are more than welcome to join, so you can find me, find my group. And one of the things that I've been very focused on recently with my second edition of my book is ferroptosis. And this is using iron as a different way to trigger cell death, because apoptosis is kind of becomes resistant. The cancer becomes resistant to apoptosis as it becomes stage 3 or 4. And actually triggering a little bit of ferroptosis is, I think, very useful. And the COC drugs, both the statins and metformin, will actually help that enormously. And this is, it causes a redox imbalance. So it's you creating free radicals and pro-oxidant environment in the cell. And this is where you have to be a little careful about which antioxidants you use and which pro-oxidants you use in your treatment program at which point. You don't have to do a ferroptosis protocol all the time. That wouldn't be appropriate, but like a little pulse, a bit like a chemo pulse to try and trigger ferroptosis to kill off some of those cells. So that's shows it's very useful for triple negative breast cancer. Just very quickly to go to an article that came out last week, and I'm just going to pose a question to maybe Dr. Kuhan about this, that showed that the metastatic spread of breast cancer accelerates during sleep. This is kind of paradoxical because you'd expect it to be more active during the day. But I don't know whether this is as a result of the clock genes, or maybe this is the competition between nutrients of the body and the cancer cell. But I'm suggesting that maybe the use of matrix metalloproteinase inhibitors like mebendazole and doxycycline, do you think they should be used at maybe a different time in the day for best effects, maybe if we're looking at trying to stop this slightly odd effect, which I thought was an interesting finding?
Fascinating. Yeah, no, I think, as always, we have to evolve and learn with the research that comes out. And as you well know, I'm sure, Jane, it comes down to the half-life of the drugs. I'm aware mebendazole has a relatively short half-life. And so, maybe looking at the dosing to kind of ensure that we have it later on in the day, like after lunch or dinner, and obviously trying to aid absorption by taking on such things with fats and oils may help that task. And I know doxycycline has a longer half-life, and I guess we kind of come up to dosing by daily dosing in terms of the concentrations in the body, but it's certainly worth considering and discussing for sure.
Yeah, great, thank you. Yeah, so it just showed that there were more circulating tumor cells at night and that they're also more aggressive. So we've had a lot of criticisms. I've seen a lot of criticisms come out recently targeted towards off-label drugs, saying they don't target the tumor microenvironment. I want to put people right about that, because there's inflammation in the tumor microenvironment. There's obviously the glucose, the fats, the protein, all of that will actually stimulate cancer. It'll provide an environment for cancer growth. So it does actually affect the tumor microenvironment in many ways, as well as mebendazole blocking this hedgehog signaling, statins also blocking the glucose receptor on the surface, having an effect on inflammation. I think people don't realize that one of statins' main effects is actually to reduce inflammation in cancer cells as well. And that metformin doesn't just reduce it in the sort of, it reduces this gluconeogenesis, which is in the liver, and a diet that is very high in carb as well as fat will actually create storage in the liver. And if you're going into a starvation, or if you're doing a sort of short-term fast, you can release extra glucose from the liver. And one of metformin's jobs is to prevent too much sugar release. So I think that's a really important point. And that the doxy and mebendazole will work on the tumor environment as well by blocking these matrix metalloproteinases. So, and another one, do off-label drugs do more harm than good? I think this is a criticism really more about the prevention of cancer and maybe the use before diagnosis of things like antibiotics and of non-steroidal anti-inflammatories, rather than actually them being used as treatment. And I think this is a slightly unfair comment, because you use them in combination, hopefully, when you're using it for treatment, rather than in a scenario where it may have caused gut dysbiosis or a problem in the gut. And I don't know whether you have any comments on that as well, Dr. Kuhan.
Yeah, of course. So, we field such queries quite often. I guess it circulates back around to the nature of the protocol and what we're trying to achieve. The intention is to use a multi-pronged strategy and draw upon the ability of the individual components to, as you said, tiotrophically affect multiple mechanisms. I mean, doxycycline, for example, the topic often comes up, and the role of the doxycycline is primarily really to kill cancer stem cells amongst the other metabolic systems. But of course, we're aware that it's an antibiotic. It's not as toxic as the other broad specs like the penicillins, and we use it anyway in real world sort of medicine for long-standing infections and skin infections like acne, rosacea, malaria, COVID-19, recurrent chest infections. In fact, we use it in the chemotherapy world as well in combination with cetuximab or panitumumab for the entirety of regimes used for colorectal cancer. So there are certain people that lean towards certain fears about the effects of, for example, doxycycline. But what we say certainly is, look, there's a good and a bad, and you've got to balance it out. And if we're worried about the microbiome, for example, in our protocol, we pulse the drug. We use it intermittently, month on, month off. We promote use of probiotics in off doxycycline months. Patients are often very well read and engaged maybe with a functional medicine practitioner and consider getting a stool microbiome test to evaluate things and get the actual data. So it's got to be a balancing act of everything. You have to weigh the pros and the cons. And with that said, with the other medicines, again, we have a very important sort of safety network in place, regular review of bloods, regular formal review of clinical symptoms, to kind of catch these issues as they occur, if they occur. But you're quite right. I mean, with each of our components, I guess we're quite lucky in that the elements have been very thoroughly researched about and used in clinical practice. So the test of time has given us that information to sort of be able to reliably prescribe.
Yeah, and going back to that point on the gut dysbiosis and doxycycline, I know a lot of people have concerns with that, particularly colorectal cancer. And something that might be of interest is maybe Saccharomyces boulardii, because that's a yeast probiotic. So it's not a bacteria, so it doesn't get wiped out by doxycycline. And actually that can help the gut integrity, can help that leaky gut. It can close up the junctions a little bit. And so that's a potential for people who are worried about doxycycline. They can still take Saccharomyces boulardii, and it actually helps EGFR signaling. So it helps to blunt that, which again is something that's upregulated in cancers like colorectal and in fact in lung cancer. So that would be a useful thing, I think, to add.
Jane, could I just come in briefly?
Yeah.
I don't want to cut you short, but I thought it'd be a lot for us to cram into the 1 hour session, and that's proving to be the case. So I'd just like to have time for Christy and also for us to get to some people's questions
Sure.
as well.
Can we just quickly, I just want to go over one last.
Yeah, absolutely. I was just going to say before you do that, if people are happy to stay on, perhaps you could paste in the chat or do a show of hands. Our panelists would be happy to stay for another 10-15 minutes so we can cover this ground and also get to some of your questions, and also be assured that, as I said earlier, this is the first of several things we're planning, so there will be lots of follow-up and information shared. But Jane, back to you.
Okay, so one of these articles that came out showing that metformin promotes the survival of dormant breast cancer cells came out, and the reason for that is that it actually creates more AMPK and fatty acid oxidation. But we also know that metformin is actually quite anti-estrogenic as well. So it helps to block some of those estrogen-driven cells. So the fatty acid oxidation was actually the problem. And I just wanted to end on the fact that actually blocking that is, there you go, the doxycycline, just to give another plug for why patients should include doxycycline in their protocol, particularly breast cancer patients. So thanks. I'll maybe come back with a few more questions at the end, and I'll stop my share now and hand you back. That's
brilliant. Thank you, Jane. And actually, I think that's a good segue, because I know we were looking at that with you, Dr. Kesslering. Before we go on to the COC Plus, maybe you want to add a comment on that.
Well, I think that it'll actually, if you pull up my first slide, I think we can kind of tie that in and go right from there. So if you can advance, hopefully you're not stuck.
No, apologies everyone. My slide deck is a bit stuck, so I'm gonna come out of this and just go back to it manually. If you bear with me.
So I will say that I do think we have to be a little bit cautious when interpreting data and looking at headlines, right? I mean, we get different and conflicting headlines every single day. So we have to remember too of maybe digging into the data. What was the level of evidence? We've talked before about, was this just epidemiology? Was it observational? Did we have control groups? What was the evidence or the differences? So for instance, like in lung cancer or smoking, you know, we saw 2,000% increases in lung cancer. So we kind of said, oh, well, there's no question because we saw it over and over and over again. But sometimes we see a relative risk of 18% or 23%. And is that real? And they're great for establishing hypotheses, but context also matters. So we have to be a little bit cautious. For instance, I think the most recent, you know, eggs are bad and then eggs are good. And if you look at what they defined as eggs, in one of the studies that said eggs was bad was anything that was made with eggs. And as you can imagine, donuts, cakes, baked goods are made with eggs, and those were included in the egg. It wasn't, you know, can you have a fried egg, you know, with your sauteed veggies? So anyway, we have to really look at context and understand where these drivers are coming from. And within the conventional world, we do lab testing, we get CBCs and CMPs, and sometimes we get some additional testing. But our newer program, COC Plus, is really trying to look past the conventional wisdom of maybe just testing glucose, but going upstream, looking earlier at what is happening with other metabolic markers, the immune system, and interpreting the data with very different eyes. So our current our current ranges are kind of the average person walking into the lab, not what is the most optimal levels. So I just want to start a little bit with a trial just to kind of, I would say, illustrate the point of looking upstream. And apparently we're having some issues with slides. So Raf, I'm on to...
I'm going to get to the slide you need. There we go.
No problem. Okay, great. So this was just a randomized trial. So true randomized trial taking patients, breast cancer patients who had non-metastatic disease, and they were put on metformin. And so we have a control group and a metformin group. And in the first table, this is looking at hormone positive breast cancer patients at 10 months, whether or not they were in the control group or the metformin group. So no other instructions or medications or diet and lifestyle interventions were given, just metformin. And you can see that the blue group did not have metastases. So there were quite a few women that did not have metastases, but it appeared to be even better in the group that got metformin. And if we look at the hormone negative patients, we can see that it's a far more dramatic improvement. But let's look upstream. Why were people with metformin still getting metastases? Or what was the difference between those groups? So when that study was evaluated for the level of insulin, hopefully we'll get to that table. Perfect. So in the first two, these were insulin levels. So I just want to point out initially or up front that these are all considered normal insulin levels. And that's why sometimes we see that, oh, insulin, that they were all normal insulin. But I will tell you the average person, this was, you know, the average American and now the world, that we all tend to have very high insulin levels. So this was a fasting insulin level. And you can see in the group that had metastases, there wasn't too much of a difference between the control and metformin group. And they were higher than those that did not have metastases. But you can see that metformin probably had a bigger impact on that insulin level than the control group, but they were still lower than the group that had metastasis. Now, these are just in the ER positive patients. So you can see IGF-1, which is a sister hormone to insulin. And those familiar with Jane's work, she has a little metro map of IGF-1. And you can see that, again, in the patients who had metastases, the level of IGF-1 quite elevated and very similar in the two groups. But those who did not have metastases had a lower levels of IGF-1, and again, a bit lower in the metformin group. So if we look at what metformin does, I think we're all aware that it reduces glucose absorption in the gut. It increases our muscle uptake. Again, another a plug for exercise. which additionally increases glucose uptake in the muscle. It decreases the amount of glucose that is created in the liver. And when we have less glucose, there is less need for insulin and IGF-1 signaling. When we have less insulin and IGF-1 signaling, we deactivate or we decrease the mTOR pathway. It typically enhances the AMP kinase pathway, which is very central to cancer cell death. It also decreases pro-inflammatory cytokines. So often our fat cells produce inflammatory cytokines, but this decreases that risk. It can improve immune response to the cancer cells, and it can inhibit stem cell replication. And Jane pointed out a very nice study that looked at how metformin with temozolomide actually had significantly higher rates of response. And we see that over and over and over again, that when we combine metabolic therapies with standard of care therapies, we tend to synergize. We tend to, I always say it's 1 + 1 = 6. It is not 1 + 1 = 2. It tends to really augment that benefit. And we see that over and over and again. So now to, how do you know? So that's my biggest thing is I'm a test, don't guess. How do you know if the metformin is lowering your insulin? So to introduce now the COC Plus program, we're really trying to look upstream and look at these lab tests that our conventional oncologists typically don't look at. So we're going to go through what does it involve, why did we add it? I think I'm already getting to why we added it, but how can deeper testing and tracking actually help you? And then what might we find from these and what might we recommend? So we can go ahead to the next slide. So what do we measure? So yes, we measure some conventional things that you probably have already seen, the CBC, CMP, liver profile, although we added GGT, which is also often not gotten. We do lipid panels. We interpret them slightly differently. We look at other enzymes. Ideally, we're getting the insulin. Would have loved to get IGF-1, but that wasn't in the package. But also looking at inflammation markers, and we'll look at these a bit in the next slide, but we also get questionnaire insights. So when we ask you to fill out the questionnaire, we are looking at things that may drive lifestyle events that may drive poor metabolism or increased inflammation. So yes, we're asking about diet and nutrition and exercise practices, but also stress levels and when do you find energy level dips if you have any? What about infection history and other diseases? Because some of these go hand in hand. We can go to the next slide. So when we do this, we kind of have a series of buckets, I guess you could say. We're looking at metabolism. We're looking at HOMA-IR, insulin resistance scores. We're looking at insulin. We're looking at insulin resistance in a number of ways, also triglyceride to HDL ratio. Sometimes we'll look at triglyceride glucose index. We look at different enzymes that are upregulated or downregulated based on metabolic state. We're looking at inflammation markers and interpreting them slightly differently, looking at CRP, which is an important inflammatory marker. That's one that gets lowered typically with statin medicines, but looking at neutrophil to lymphocyte ratio, platelet levels, platelet to lymphocyte ratios, really trying to think through all of the different biochemical reactions and trying to identify gaps in our underlying health. My goal is to help the host improve their health so that they can better optimize their cancer outcomes. They're not coming in to therapies in a depleted state, that we're not over consuming certain things or under consuming certain things, that we're optimizing nutrients. So vitamins and minerals, we can identify some gaps there. Sometimes I identify things that do point to maybe some gut dysbiosis, maybe toxic burden, maybe we have glyphosates and plastics and phthalates. So it's really trying to be a little more comprehensive. As the providers working in the COC Plus are really just at this juncture doing a lot of diet, lifestyle, and nutritional supplement coaching. We may change the COC protocol medications based on what we're seeing. Do we need to up one or down, decrease one? But for those areas that we really can't manage, so if I do see some gut health or toxin evidence, I might refer a patient to find a provider close to them that can do that. I think we can go. And let me just summarize. The little stoplights on the right there are just ultimately would be the report that the patient gets, kind of breaking these all down, kind of taking each lab and color coding them so you can see the area that we would want to work on with suggestions, as well as some formulated handouts that we'll be sharing. And then our goal is to, obviously help the patient make those changes with information, and then retest to say, did what we set out to do actually happen? And I do find actually pretty impressive stuff. When we actually do this, I see it working better. I see tumor markers going down. Sometimes I've seen end stage patients just looking for quality of life. And this actually, we can identify areas that maybe they want to focus on just for quality of life purposes. So I find it to be really exciting that if we, again, can really dig deeper, as opposed to just keep throwing things at the problem, but really getting a better understanding for what's going on under the hood, and can we optimize the host. So I'm excited to be a part of this new endeavor.
That's brilliant. Thank you very much, Christy. So before we get to some questions, and I do appreciate that some people will have a hard stop as we come up to 7 o'clock or 2 o'clock in the US, but there will be materials that we're going to be sharing. As I said before, there'll be follow-up events, and fantastic if people can stay on, because we will get to some questions. So just a few take-home messages then. In terms of COC Plus, it really builds on our core protocol offering with deeper testing. And it's the testing that's going to inform these recommendations that clinicians will give. And then we retest to see, as Christy said, how things are going and what impact those interventions may be having. And another thing to say just on COC Plus, it's really something that is available in the States and here. But there are some differences in onboarding for patients, depending on whether they're an existing patient already on the COC protocol, or whether they're not yet a patient with COC on the core anti-metabolic adjunctive medicines. And depending on the case, we might often recommend that a patient first comes in, if they're not a patient with us, and begins that core protocol, gets safely established on that. That's a set of new interventions. We might fine-tune that in that initial period, and then look to add the COC Plus testing to that as early as the first review appointment stage. But that's a case-by-case clinical team evaluation. But the key takeaway really is that if you're not an existing patient, reach out to us in the channels that we'll share with you. And if you are an existing patient, then it's a program that is sort of, in a sense, easier to add right away via an online onboarding journey. But thank you. And just to say again that with Jane, we are really committed to empowering patients. We learn from patients. We want to keep this exchange of information and engagement going. And there will be further events planned. So, for example, I think we've talked about Professor Lazanti earlier on, but he's somebody who's done extensive research on doxycycline and other medicines, particularly as regards inhibiting metastasis. And he would be open to joining us for a follow-up session. So we'll be coming back to you on all of that. But again, thank you for your time. And now we'll get to some questions. Jane, did you have a couple that you wanted to start with first? I know that you'd received some directly yourself. So if you wanted to start, and then I could pick up with some others that we've received. Sorry, Jane, you're on mute.
Sorry, again. Okay. So really the I'll just start with maybe one, and one that I've seen a lot in a lot of emails that go around and things, that metformin damages the liver. And I think there's not much truth in that, but I'd just like you, Dr. Kuhan, maybe to comment on that and just to reassure people about metformin.
Yeah, no, thank you, Jane. I mean, the short answer is no. I'll backtrack and say that nothing in life is 100%, but what I mean is, having had extensive experience now prescribing metformin in my job here, but of course the vast experience for how long metformin has been around, 70 odd years, there certainly is not enough proof to suggest that metformin is that dangerous in the liver. I mean, we prescribe, of course, in this country by using the British National Formulary. Simply put, there are no recommendations for dose adjustments, even in hepatic impairment. So there's that aspect of things, I guess, but ultimately, as I kind of touched on before, regardless, it's dependent on the specifics of the situation. So needs to be considered. And
Kuhan, let me throw something in there.
Yeah, sure.
Just for sake of time, but typically when we see, metformin damages liver, who's on metformin typically? Are diabetic patients, and our diabetic patients aren't necessarily told to change their diet and lifestyle. And they are high insulin state, and they are creating fatty liver, day by day by day, and their liver function tests are going up. And so again, I think we have to think about context and do we have true randomized trials in people who are eating low glycemic diets and exercising, and is that same thing hold true?
Yeah. And I certainly have not seen it be, there been a direct correlation with those that have had liver dysfunction from using metformin. We can talk about the other medicines, but as you mentioned, non-alcoholic liver disease, again, studies in the past with the use of metformin in such indications. So the short answer is no, Jane. We haven't any obvious proof of that being a concern.
Yeah, that's great. Okay, and there's obviously some suggestion that they damage, that both statins and metformin damage the mitochondria, but the effect is really more of a blunting of some of this creation of ATP and cancer. I think people need to see cancer as more needing energy, and it's a blunting of that excess energy that the cancer cell makes. And in fact, mitochondria can actually be recreated from a result of taking metformin. It creates mitochondrial biogenesis. So it's not necessarily damaging as such, but it is actually, it's almost beneficial. It allows you to recreate some mitochondria to sort of function more normally. So I think there's a lot of misconception out there from what's being read, what's being said, and a lot of Chinese whispers that have been misinterpreted along the way. But I want to hand back to maybe Raf to sort of have a look at some of the questions that people have been asking.
Yeah, thank you, Jane. So there's quite a few on a theme around when is the best time to use the COC protocol. So I'd like to put this out maybe to the doctors initially, and maybe you, Christy. Should you use the protocol if you're in remission? Would there be a time when somebody can come off the protocol? Maybe when somebody is 5 years with no evidence of disease, or is it a lifetime thing? And a related question, if I'm currently in remission, somebody asks, do I start the protocol or wait until there's progression?
Loaded question. No, my bias is that the combination of therapy and metabolic therapy, again, synergizes effects. So the sooner we can get involved, I think, the better. In all of those pieces, including the COC Plus helping to optimize those metabolic therapies. I think that as far as if somebody is doing this with a curative intent, standard of care treatment, and they become NED because of surgery and chemotherapy, et cetera, I think then it becomes more of a risk benefit analysis. What is your cancer? How likely is it to recur? How quickly might it recur? How well are you doing from a metabolic and immunologic health? Are you doing all of the other pieces to improve your health? Do you have any evidence of circulating tumor cells or tumor markers that are still elevated? So I think there's so many things that come into that discussion that it's truly an individual decision, obviously with guidance from the doctors, kind of helping to weigh risk and benefits. Maybe you decide to do it, in the short term to continue to optimize those things that we can't see, right? Because we know that there are NED people who do recur. So that means there was still cancer there. But if you are optimizing and following markers early, I think Jane was good about following markers. And as soon as you see things going in the wrong direction, you're like, okay, I got to regroup. I got to rethink what else do I need to do, or what has fallen off. Maybe I stopped exercising. I started eating cake at everybody's birthday party, can we get back on track and re-optimize? So as much as I would love to give a one-word, one-sentence answer, I think it is so personal in the type, the person, what else they're doing. And I think that those are actively involved in their care and their health and maintaining that health. I think, we have, I wouldn't be as dramatic, but I think that, again, incorporating COC Plus, I don't have cancer. I'm hoping to avoid cancer. I do these labs in myself at least every year because I want to know, oh, something's going wonky. What am I doing different? What is my stress level? So I think that prevention is key for those that don't have disease, but that falls into the NED folks too, right? We are trying to prevent recurrence.
Yeah, well, I think that's fantastic. And I think we've had similar questions before. I guess one of the aspects there is that several of the medicines that we use actually have good evidence associated with them in a preventative setting, like metformin and doxy inhibition of cancer stem cells. And Dr. Kuhan, I don't know if there's anything else that you would like to add to.
No, I think Christy summarized it perfectly, to be honest with you. I mean, more and more, we should be thinking of cancer as a chronic disease. And if we then go on to talk about metabolic syndrome, as a hallmark, or metabolic dysfunction being a hallmark for disease manifestation, whatever disease is, cardiovascular, neurological, inflammatory disorders, etc. The fight is in some way always on. Is the word cure a romantic term? And should we not be striving? This is the message, I guess, of one of the big messages of today's talk. We should be striving to do whatever we can within our own remit to try and optimize our chances or reduce the chances of recurrence of disease. So ultimately, with the Care Oncology program, I always reflect back and think when I first started, a lot of the patients were necessarily maybe later stage, having progressed through multiple lines of treatment. But because of the endeavors and the messages and the people fighting the fight, and Jane and all the others in the forum, ourselves included, now we see patients having just been diagnosed. Or having just completed their first line of treatment. And so if you could evolve further to a point where, we're preventing, as Christy mentioned, we're preventing that manifestation of disease, we're picking up metabolic dysfunction early, then ultimately that's amazing, that's great. So I think it's a natural evolution of all of this. But to that question, it is ultimately a case-by-case discussion, dependent on the individual specific circumstances. So again, not to bang the drum, but the COC Plus is a great evolution of all of that, to be able to use blood markers to help evaluate what else you can do for yourself.
Great, thank you, Kuhan. Another theme that I can see in a lot of questions is various people are reporting difficulty in tolerating one or more of the drugs at certain points. And again, I think COC Plus, along with our existing evaluation of what may be the causes of tolerability issues, that will give us more insight into what might be going on there, whether it's to do with somebody's disease states, possibly other conditions, existing medicines they're taking for their cancer, for other reasons. And I think it also opens up a suite of additional interventions. So I know, Kuhan, you and the other doctors, and Christy, you and your colleagues in the States, we're always working out what can be done to adjust people's protocols and tailor them to maximize tolerability. But now I think we have a raft of additional options informed by the insights from the testing that we can also consider. So that leads me on, and we'll come on to, it might be an interesting follow-up session to look at tolerability and side effects that are reported and how we can help people navigate through that. But it leads me on to another question, which I'll direct to you, Jane, initially, which is, what is the impact of food on cancer?
Oh, well, it's massive. I think if I hadn't changed my diet, I don't think I would be here now. I think there are many ways that you can starve cancer. So you've got things that, I mean, I heard Walter Longo talk last week, and he was very, you know, the whole fasting mimicking diet is very compelling. All the evidence he was showing for that, particularly with, in combination with chemo and generally with most treatments, but especially with chemotherapy. And, you know, there are intermittent fasting protocols. There are lots of different methods that you can use. It doesn't necessarily have to be just one approach. I've seen people maybe go on to carnivorous diets who have got a very glycolytic cancer do well. So you know, there's no hard and fast rules about it, but certainly a low glycemic diet is kind of like the standard. Ketogenic diets can be very useful, but of course they can drive BRAF, you know, BRAF cancers are apparently driven by ketones, so that may be a potential issue. So you know, there are lots of different things you need to look at when you're considering your diet and which one you think is the most appropriate for you. So Chrissy, yeah,
I'll throw in a couple of things. So yeah, we all know that, you know, sugar is a big issue. We know that metabolic syndrome, like in the early stage breast cancer, low oncotype DX breast cancer patients, if you had metabolic syndrome, you were 21 times more likely to develop a recurrence than if you were, you know, so that's why I love the COC Plus. Look at your insulin, look at your HOMA-IR, look at these measures. As far as the BRAF, I'll just throw out a point that was in a cellular culture, and it was grown in a high insulin median. So
okay.
When you add ketones to insulin, that would not be a natural state, and really it's being driven by insulin. And there have been some subsequent studies that have kind of disproved that. I think that the fasting, you know, but we can't fast forever, right? We have to eat, we have to fuel our body, our normal, we have essential amino acids, we have essential fatty acids, or we will die. So we need to fuel our normal. So either doing it cyclical, which Dr. Longo has some beautiful data on, cycling it around chemotherapies. There's a growing body of literature that kind of fasting mimicking diets actually change epigenetics. So it's not just, you know, losing weight. It is actually, can we change epigenetics? So just because we have a gene, can we turn it off? You know, can we turn good ones on? And so I always say it's not really about the food per se, right? It's about the markers. So some people can eat a carnivorous diet and their markers look great, and others, you know, can do a vegetarian diet and their markers look good. I think that it's very individual. We all come from different areas in the country. We all have different, you know, potentially ancestral diets, but I think that it's always about the metabolic state, not necessarily the foods exactly that you are eating.
Yeah, I think that's a very good point. And I think a lot of people get very twitchy about glutamine in the diet, and, you know, should they be cutting out glutamine? Of course, that's the most abundant protein in your blood, so you cannot possibly cut it out. The point is you're trying to stop the access of the cancer to the glutamine. It's not necessarily chopping it out of your diet to an excessive point. Certainly reducing protein in your diet is important, but it's the access that cancer has to it. So things like green tea, you know, the EGCG extract is very good at blocking glutamine getting into the cell. So those are methods, and I think people do get very confused about protein. But certainly cysteine can drive resistance because it creates that antioxidant glutathione, which means that you can get resistant to some of the treatments like chemo and radiotherapy, and also ferroptosis. So this is something that people need to understand a little bit more about.
It's all about context.
Yeah, and depending on what part of the program you're in, sometimes I even now suggest a methionine-free diet if they're going to do a ferroptosis protocol. So that it's like you know, it goes hand in hand with a ketogenic diet maybe at some points. So it's it very much is what is suitable for you, but you really have to understand your body and testing. I took tests, I tested all the way throughout. I think you really need to know what's going on in your body.
Fantastic, thanks both. I wanted to pick up on another one that was a bit of a common theme, and it speaks to the combination of our protocols, what Jane used, what we use at COC, in combination with standard of care treatments. And we spoke about the potential to enhance standard of care, as per the the illustration you showed with the temozolomide, Jane.
Yeah.
But some people have concerns that medicines could actually work against chemotherapy in some format. And
yeah,
I wonder whether you wanted to talk about that a little bit, and then I'd move it on to Kuhan to have a
yeah
at that one.
Well, I'll just quickly chirp in about the antioxidant and pro-oxidant effect that some of these supplements have. But in fact, a lot of these so-called antioxidants have cancer-starving properties that are way more beneficial than their antioxidant properties. So curcumin, for example, it has far more benefits on inflammation and things like that. It blocks mTOR, all sorts of things that are really beneficial for cancer beyond the fact that it's an antioxidant. So I think that people don't necessarily need to see all supplements as antioxidants. Some of them are actually pro-oxidant, and they will actually help fuel this sort of free radical effect, so that you're actually complementary and synergizing with things like chemotherapy. Piperlongumine, which is long pepper, for example, will actually promote extra free radicals because it helps block that cysteine import into the cell. So that there are, you can't just rule out all antioxidants as being one and the same. And I think that's the point, is that, in certain contexts, they will be pro-oxidant, and actually in different doses as well. So oral vitamin C, for example, is an antioxidant at a very high dose. Given intravenously, it is pro-oxidant, so it has a completely different effect. And this is something that people also need to, this also transfers across to quite a few of the other supplements as well, and that at a high dose, they have a completely opposite effect.
Yeah, Jane, and I guess in the same vein, I mean, we're not using, for example, metformin and statins for their antioxidant qualities, but
no.
For a bunch of other reasons. And I guess from the real world observational point of view, doctors don't need to stop statins or metformin or whatnot during chemotherapy or radiotherapy. In fact, we use doxycycline with chemotherapy as well. So, and that's again based on the fact that we know that these drugs are again safe to use because of just real world data. So, I think it's just an oversimplification, as I guess is what you've just explained as well.
Yeah, and I will say that the data that it's based on is relatively limited. They just kind of said, oh, this is how chemo and radiation work, therefore don't do these things. And yet there is randomized data in the breast cancer literature that those women who maybe are on fish oil or high dose omega-3s during chemo actually have less chemo brain and less neuropathies. And yet it's a medicine that's constantly being, cancer patients are told to hold during treatment. So we do have to take into account what they're telling us, but I would love for them to dig into that literature to really make it a more science-based recommendation.
Agreed.
Fantastic. Jane, did you have one more question that you wanted to put?
In terms of results of clinical trials, so you're going to come out with some more data. We've had the GBM, and I'm just wondering whether the COC are actually coming out with any more trials on any of the other cancers.
Kuhan, do you want to speak to that?
Yeah, so we've been actually internally auditing our work. And so in the follow-up sessions, we do hope to present some data in prostate cancer, ovarian and breast cancer, not to mention the extension of our GBM data. So yeah, look forward to it.
Okay, great.
Okay, fantastic. So I think we'll wrap up there because we're 20 minutes past the hour. But thank you again, to all our panelists and to all of you for joining us. We've really enjoyed it. I hope it's been informative, enjoyable for all of you. As I said, there'll be various follow-up that will now be happening in the next days and weeks, and there are other events that we're going to let you know about. I'm just going to pop up this slide again. Just don't worry about screenshotting this or saving it in some other way, because we'll be sending it to you on email as well with lots of other information. But thank you again for all your time. It's been an absolute pleasure. And I don't know if you have any closing remarks, Kuhan, Christy, Jane.
I
Nope.
just say again, thank you so much. It's great to have this opportunity. Thanks, Raf. Obviously, personal thanks to you for helping get this set up. And we've been discussing this for some time. It's about time, I think, we had this forum to sort of just talk openly, you know, show off our expertise, provide a forum to talk about hot topics. And I hope this is the first of many, you know, posts, webinars, podcasts, etc. But really looking forward to it. And thank you so much for the patience and the support that we've received in putting this together. And thank you so much to Christy and of course Jane for everything that you've both done. So looking forward to the next one.
Great, and I just want to reiterate that it was wonderful to collaborate like this, and I really enjoyed it. So thank you so much.
Brilliant. Okay.
And I'm just saying thanks because I'm hopping off to see the next COC Plus patient.
Fantastic. Thank you all. Thanks, everybody.
Okay,
See
thanks,
you in the
Ralph.
next one.